Hello friends, welcome to Medical Guruji. In the last lecture, we discussed about spectrum of activity of antibiotics, about the narrow spectrum antibiotics and the broad spectrum antibiotics. Today we will discuss pharmacokinetics and pharmacodynamics of antibiotics, which involves absorption, distribution, metabolism and excretion of antibiotics, dosage forms and route of administration, time dependent versus concentration dependent killing. So we are going to start with pharmacokinetics first. So what is pharmacokinetics? The pharmacokinetics refers to the movement of drug within the body, encompass the process of absorption, distribution, metabolism, and excretion. That is short form is ADME: absorption, distribution, metabolism, and excretion. Understanding these processes is very much important for determining the appropriate doses, route of administration, and frequency of antibiotic administration. First one is absorption. Absorption is a process by which antibiotics enter into the bloodstream from the site of administration. The route of administration can significantly impact the absorption rate and bioavailability of the antibiotic. For example, various route of administrations are oral, that is PO, written as PO in the prescription per oral. Antibiotics taken by mouth are absorbed through the gastrointestinal tract. Factors such as food intake, gastric pH, and intestinal motility can influence absorption. For example, tetracycline's absorption is reduced when taken with dairy products due to calcium binding. Second route is intravenous, that is directly administered into the bloodstream, ensuring 100% bioavailability. This route is preferred for severe infection or when rapid therapeutic levels are required. Third route is intramuscular. Antibiotics injected into the muscle are absorbed into the bloodstream. This route provides a relative rapid absorption compared to oral administration. Fourth one is topical, that is applied directly to the skin or mucous membrane for localized infection. Absorption is typically minimal but sufficient for treating superficial infection. Second point among the pharmacokinetics is distribution. Distribution refers to the dispersion of the antibiotic throughout the body, reaching the site of infection. Factors affecting distribution include tissue permeability, blood flow, protein binding, and the presence of barriers like blood-brain barrier. In the distribution, key points are volume of distribution, that indicate the extent to which antibiotic distribute into tissue. A high volume of distribution means the drug extensively penetrate tissue, while a low volume of distribution indicate limited tissue distribution. Second point is protein binding. Many antibiotics bind to the plasma protein. Example, albumin. Only the unbound, that is free, fraction of the drug is pharmacologically active and can exert its therapeutic effect. Third point is metabolism under the pharmacokinetics. So metabolism is the process by which antibiotics are chemically altered, usually in the liver, to facilitate their elimination. Metabolic pathways can include oxidation, reduction, hydrolysis, and conjugation. One of the special type of metabolism is first pass metabolism. The oral antibiotics undergo significant first pass metabolism in the liver, which reduce their bioavailability. This is not an issue for intravenous and intramuscular routes. Active metabolites. So some of antibiotics are metabolized into active compound that contribute to the therapeutic effect. For example, the prodrug sulfasalazine is metabolized into the active inflammatory agents sulfapyridine and 5-aminosalicylic acid. Fourth point among pharmacokinetics, that is last, is excretion. Excretion is the removal of antibiotic from the body, primarily through the kidneys or by urine, or the liver through bile. Understanding the excretion pathway helps in determining dosing intervals and adjustments. especially in patients with renal or hepatic impairment. Key points in the excretion is there is renal excretion. Antibiotics like penicillin and aminoglycosides are primarily excreted unchanged in the urine. Dose adjustment may be necessary in patient with impaired renal function. Second is biliary excretion. Antibiotics like macrolides and tetracyclines are excreted via the bile and can undergo enterohepatic recirculation, prolonging their half-life. Next point is pharmacodynamics. So pharmacodynamics refers to the effect of antibiotic on the bacterial cells and the relationship between drug concentration and its therapeutic effect. Key pharmacodynamic parameters include the minimum inhibitory concentration (MIC), time-dependent killing, and concentration-dependent killing. So first one is MIC. What is MIC? So MIC is minimum inhibitory concentration, that is the lowest concentration of an antimicrobial agent or antibiotic that prevent visible growth of a microorganism in vitro. It is a critical measurement used to evaluate the efficacy of antibiotic against specific pathogen. So next question arises here is how MIC is determined. So MIC determination is mainly by two methods. First is the dilution method, in which a series of test tubes or wells containing a liquid growth medium is prepared, each with a different concentration of the antibiotic. Then a standardized number of bacterial cells is added to each tube or well. After incubation, the concentration at which there is no visible bacterial growth or cloudiness or turbidity is observed is recorded as the MIC. Second method is E-test or gradient method. In this method, a strip impregnated with a gradient of antibiotic concentration is placed on an agar plate inoculated with test organism. After incubation, the point where bacterial growth inhibition stops along the strip is read as the MIC. So why we are need to know the MIC. So what is the significance of MIC? First significance is the MIC help in determining the potency of antibiotic against a specific pathogen. That is, lower MIC value indicate higher potency. Second is the guiding doses decision. So clinicians use MIC value to select the appropriate antibiotic doses that will effectively inhibit the growth of pathogen in a patient. Third significance is MIC values are compared to predefined breakpoints set by organizations like CLSI or UCAST to determine if the organism is susceptible, likely to respond to treatment. If it is intermediate, then response may be require higher doses, and if it is resistant, then likely to resist the treatment. So limitation of MIC are, it does not account for the host factors like immune response or tissue penetration of the drug. Second, it provides static information while dynamic interaction in the body, for example, pharmacokinetics and pharmacodynamics, also influence the treatment efficacy. So in summary, MIC is a vital tool in antimicrobial testing, aiding the clinician in selective and effective treatments and helps in combating antimicrobial resistance also. Second is the time dependent killing. Time dependent killing is the phenomena where the efficacy of an antibiotic depend on the duration that its concentration remain above the minimum inhibitory concentration of the target bacteria. In this case, the longer the antibiotic concentration stays above the MIC during dosing interval are more effective, and it is at killing bacteria. Mechanism of action of time dependent killing is the time dependent antibiotics works by continuously inhibiting bacterial process such as cell wall synthesis or protein synthesis over the time. These antibiotics do not rely on high peak concentration for their effectiveness. Instead, maintaining a steady concentration above the MIC is critical. Example of time dependent antibiotics are, first one is beta lactams including penicillin, cephalosporins and carbapenems. These inhibit bacterial cell wall synthesis by targeting penicillin binding proteins. Their bactericidal activity depend on the maintaining concentrations above the MIC for a significant portion of the dosing interval. For the detailed mechanism of action, you can refer to the second video, that is on the mechanism of action, and for classification, you can refer to the first video. So second is vancomycin. Second example of time-dependent antibiotic is vancomycin. It inhibits the peptidoglycan synthesis in gram-positive bacteria. Its efficacy is also time-dependent, though it has some concentration-dependent characteristics. Third example is macrolides. Example under the macrolide is erythromycin. These inhibit the bacterial protein synthesis by binding to the 50S ribosomal subunit, and their activity is enhanced by prolonged exposure above the MIC. The key pharmacokinetic parameters are the critical parameter for time-dependent antibiotic is T should be more than MIC, which represent the percentage of dosing interval during which the drug concentration remain above the MIC. And for optimal efficacy, T should be greater than MIC, should typically be at least 40 to 50% of the dosing interval depending on the specific antibiotic. So clinical implication of the time dependent killing is first is frequent dosing. So time dependent antibiotic often require more frequent dosing or continuous infusion to maintain effective concentration above the MIC. Second is to minimize the resistance. Maintaining steady drug level reduce the risk of bacterial regrowth and resistance development. Third is in the therapeutic monitoring. For drugs like vancomycin, therapeutic drug monitoring ensures that concentration remain the effective range. Time-dependent killing contrasts with concentration-dependent killing, where the efficacy depends on achieving high peak concentration related to MIC. So we will now talk about the concentration-dependent killing. Concentration-dependent killing refer to the phenomena where the efficacy of an antibiotic depend on achieving high peak concentration related to the minimum inhibitory concentration, that is MIC of the target bacteria. The higher the drug concentration above the MIC, the greater the bacterial killing effect of the antibiotic. So mechanism of action of concentration dependent antibiotics, in which the rate and extent of bacterial killing increase as the drug concentration rise significantly above the MIC. These antibiotics rely on achieving a high peak concentration, that is Cmax, or a high area under the concentration time curve, AUC, relative to the MIC for optimal effectiveness. Examples of concentration dependent antibiotics include, first one is aminoglycosides like gentamicin, amikacin, which irreversibly bind to the 30S ribosomal subunit, causing misreading of mRNA and production of defective proteins. In the high concentration, it leads to the rapid bacterial killing. Second example is fluoroquinolones like ciprofloxacin, levofloxacin. These inhibit the DNA gyrase and topoisomerase 4 enzymes essential for bacterial DNA replication. Increasing in the concentration of this drug amplifies bacterial DNA damage and killing. Third example is metronidazole. This disrupts the bacterial DNA by forming toxic reactive metabolites in the anaerobic conditions. Higher the concentration, increase in the DNA damage and bacterial death. So key pharmacokinetic parameter include the critical parameter for concentration dependent antibiotic is the ratio of Cmax and AUC. Cmax is peak drug concentration to MIC and AUC is area under the curve to MIC. So higher ratio correlate with increased bactericidal activity, and AUC represent the total drug exposure in relation to MIC. So what are the implications of this concentration dependent killing? So dosing implications are single high dose. Concentration dependent antibiotic are typically administered in single large dose to maximize peak concentration and effectiveness. Second is extended dosing interval. Allow time for the drug to clear from the body and minimize toxicity risk without reducing the efficacy. There is an effect known as post-antibiotic effect, PAE. Like many concentration-dependent antibiotics exhibit a post-antibiotic effect where bacterial growth remains suppressed even after drug level drop below the MIC. This allows for less frequent dosing. Clinical application are the concentration dependent antibiotics used in severe infection where bacterial killing is crucial. For example, aminoglycosides and fluoroquinolones are commonly employed in life-threatening infection like sepsis and complicated intra-abdominal infection. In summary, concentration dependent antibiotics maximize their efficacy by achieving high drug concentration relative to the MIC, which making their pharmacodynamic approach distinct from the time dependent killing antibiotics. Overall summary of today's lecture is we read about the pharmacokinetics. In the pharmacokinetics, we discussed four things, that is absorption, which determine how the antibiotic enter into the bloodstream. Some antibiotics require oral intravenous administration due to varying bioavailability. Second, we discussed distribution, which describe how the antibiotic reaches to the site of infection, and factors like lipid solubility, protein binding influence the distribution. Third, we discussed metabolism, that is how antibiotic is broken down, and some drugs are heavily metabolized like rifampin, while others are excreted unchanged. Fourth, we discussed excretion, which describe elimination of drug from the body, usually via urine or bile. That is, aminoglycosides are renally excreted. Then we discussed the pharmacodynamics, which refers to the effect of antibiotic on the bacteria, and in which we discuss the mechanism of action and the killing patterns, that is time dependent killing, concentration dependent killing, and lastly we discuss the post antibiotic effect, which is the continued suppression of bacterial growth even after the drug concentration fall below the MIC. So PK and PD guide dosing regimens to ensure optimal antibiotic effectiveness while minimizing the toxicity and resistance. If you like the video and content, then please do share and subscribe our channel and share among your friends, colleagues also. In the next week, we will discuss clinical uses of antibiotics, their indication, that is the indication for antibiotic use, empirical versus definitive therapy, and where are the prophylactic use of antibiotics, and antibiotic stewardship, and what is rational prescribing of antibiotic. We will discuss in the next week. If you missed any lecture before this, then do watch from the playlist Basic Course on Antibiotics for Medical Students. Thank you.